Joining us tonight. My name is Chris. I am a medical student at UT Southwestern. And on behalf of the Adaptive Sports Coalition, I have the privilege of introducing our speaker for our education series tonight. It's Dr. Megan Ware. I've been waiting a while for this talk, so I'm really excited. I'll go ahead and introduce her. Dr. Megan Ware is an assistant professor in kinesiology, health promotion, and recreation at the University of North Texas. She received her BS degree in health and human performance at the University of Tennessee at Chattanooga and her MS and PhD from the University of Georgia. She completed a postdoc fellowship in the Department of Epidemiology and Cancer Control at St. Jude's Research Hospital. Her research focuses on developing a better understanding of affective or emotional factors influencing physical activity behavior and exercise engagement in populations that experience chronic disease and disability. We're really excited that she's taken the time to speak to us tonight and kind of share what she knows. So with that being said, I'll go ahead and hand it over.
Thanks for the intro, Chris. I'm very excited to be here. I'm going to be speaking on some psychosocial factors influencing participation and adherence to physical activity. So I know Chris gave a nice little intro. I have like one slide, so I'll fly through it. But I did my undergraduate degree in health and human performance at the University of Tennessee at Chattanooga, after which I chose to move to the University of Georgia for a master's and PhD in kinesiology under the guidance of Dr. Kevin McCulley, who is a physiologist in the area of disability studies. And then I moved on to St. Jude, as Chris mentioned, in epidemiology and cancer control, and started working with larger data sets and trying to explore and understand childhood cancer survivorship. But for the purposes of this talk, I'm really going to be focusing a lot on the earlier work within my career, the stuff that I was doing, particularly at the University of Georgia while I was still a student before transitioning to St. Jude. I had a lot of amazing experiences that helped shape my research interests and agenda, all of which included working with individuals with disabilities. As you can see, picture here, there's several folks that I can credit with my research interests. I can say thank you to them. The first of which being Nicole, who's pictured here on the left. I was her student trainer for the International Special Olympic Games that took place in LA in 2014. She medaled in all three of her events. And I had the privilege of training her for a year leading up into the actual Olympics. And then on the right, there's a larger photo from my time at the University of Georgia, where I was an instructor of record for an undergraduate course that allowed individuals with disabilities from the Athens area to come onto campus and work with undergraduate students who were pre-PT, pre-OT, pre-PA, a variety of pre-health professions. And this class was super important to my understanding of where I wanted to be in terms of in the research field. And it's instrumental to a lot of the research that I'm going to be talking about today. So I wanted to provide a little bit of context around this particular course because it's so important to that. The course is free of charge for individuals who want to participate. And it's also mutually beneficial for the students because they get credit hour. It's actually a credit hour course at the University of Georgia. It's a service learning course, which is service learning is now a requirement, I believe, at the University of Georgia for every single student graduating with an undergraduate degree. So it's this mutually beneficial, very community-based environment where students are getting to work with an individual with a disability. And I'll be talking about this course later on in the presentation. So I just wanted to give a couple of facts and statistics around disability, as well as go over just a couple of things related to behavior change and how we conceptualize adherence and participation in larger behavior change before moving forward into psychosocial factors that influence participation and adherence. I'm going to talk about a couple of different things like symptoms, social interactions, implications of those findings, and then how we can help people properly exit sport. And then questions, hopefully you guys have some, hopefully there's time for some. And I would really love to discuss further if anyone's interested. So I'll get started. Essentially, the number of individuals with disabilities in our population, the United States population, is on the rise. As you can see here, these are data from the annual report on people with disabilities in America. from the American Community Survey, the last updated data set from 2022. And you can see that around 14% of the United States population identifies as having a disability. And again, this is from the American Community Survey, where there are 6 questions used to determine disability status. So it could be anything from reporting a visual impairment, a mobility impairment, a cognitive impairment, etc. And that equates to about 46 million individuals. So this is a rising population. This should become more of a public health concern as we move forward, because this trend is only expected to rise with more of the population aging. Since I'm new to Texas, I just wanted to throw this in here, some Texas-specific data. This is from the Texas Workforce Investment Council. It's their report on individuals with disabilities. And again, because it's the Workforce Investment Council, it's really focused on individuals who are able to enter the workforce. So individuals starting at age 18 up into like 60s, mid 60s or so, and then it starts to drop off. They don't necessarily poll those individuals because they're not contributing members of the workforce necessarily past a certain age range. But what I wanted to point out is the little box that highlights our geographic location here in North Texas, areas 4, 5, and 6. 4 representing North Central Texas, 5 Tarrant County, so Fort Worth, I believe, area, and then 6 Greater Dallas. And what we see is that the prevalence of individuals reporting having a form of disability in this area is anywhere between 89,000 people to around 400,000 people. And that makes us a prime area for doing this kind of work and doing the type of work that the Adapted Sports Coalition is doing, and hopefully I'm wanting to do moving into this area. Jumping back to our American Community Survey data, I just wanted to briefly touch on employment statistics as it will pertain to what we're going to be talking about here in a little bit. As we can see, in 2022, there was a historic high for our country, or at least for American Community Survey's monitoring of employment in individuals with disabilities, with somewhere around 45% reporting being employed. But we can still see there's a huge disparity between that and individuals with, individuals without disabilities, where somewhere around 80% of those individuals are employed. And that leads to different access and different potentials and services for individuals with disabilities. And that's really illustrated well here with the poverty statistics, where we can see generally the trend has sloped a little bit over time, but it looks like we're right back to where we were in 2008 with somewhere around 26% of individuals with disabilities reporting being in the poverty bracket, compared to around 12% of individuals without disabilities being in the poverty bracket. Now, you might be wondering, why am I talking about that when I'm talking about exercise and physical activity? And one of the reasons why I like to talk about that is because we have to understand that behavior is a result of multiplicative influence. Essentially, any one behavior choice is dependent on external and internal factors, some of which are within the individual's control, some of which are outside the individual's control. And so when we think about behavior, we think about behavior in terms of how many different things are contributing to that decision. And I really like illustrating that using the social ecological model. And for those of you who are not necessarily familiar with that, it holds that there are different levels of influence in any one behavioral decision, individual level influence. So the things that are pertaining directly to you, things like your gender, your age, your race, interpersonal. So that's more along the lines of your relationships, organizational, directly pertaining to like school, work, places that you are in quite often, your community, which can be your built environment, as well as from like a larger level of policy level. So all of these things are interacting to create any one individual's decision or influence any one individual's decision whether or not to engage in activity. And for the purposes of this presentation, we're focused on physical activity. Now, kind of couching this more in a disability health kind of mindset, there have been several models that have been created to try to illustrate what levels of influence there are for behavior or engagement in activities for individuals with disabilities. I really like this one from the World Health Organization, the International Classification of Functioning Disability and Health, or the ICF. The overall aim of creating this model was to provide a unified and standard language and framework for the description of health and health-related states, but it does a great job of defining different health-related components and how they contribute to someone's ability to participate in activities and in activities of daily living. Now, what we're seeing is, personal factors, environmental factors. Some of these things might be reminiscent of what we saw in the social ecological model in the previous slide. But again, we're talking about these things in a little bit more focused context. So now that I've kind of gone through that, I'm going to start working into some of these psychosocial factors. Generally, I wanted to discuss briefly adherence and participation in physical activity and exercise has been studied in the general population. So just so you have a frame of reference of what we are kind of comparing individuals with disabilities to potentially. There have been some very marked studies that observe demographic factors, cognitive factors, social factors, environmental factors that influence continued adherence and participation in physical activity in the general population. And there are just a few examples listed here. You're going to see these things potentially come up again. But I wanted to give you a frame of reference for what's to be expected kind of in the general population. Now, pertaining kind of, going back to focusing in disability studies, we're going to be focusing on personal factors and environmental factors for this portion of the presentation. Still in the psychosocial realm, but really thinking about that lower half of the model. And I wanted to start out by discussing something a little bit more on the personal side of the model. So thinking more along the lines of those very individual level factors. In discussing one of my dissertation studies titled The Role of Worry in Exercise and Physical Activity Behavior of People with Multiple Sclerosis. And during my doctoral work, I was actually a clinical trial administrator and an exercise interventionist on a multi-site PCORI trial, where we were exercising folks with multiple sclerosis for 16 weeks to monitor health outcomes, including walking function. And during that time, I realized that there are huge issues in this population with fatigue. And so I decided to focus my dissertation on fatigue. And after doing my initial analysis, I realized that there were some other things emerging from the qualitative data that I collected pertaining specifically to worry. And I wanted to sit back and actually take a look at that and try to understand how worry influences exercise and physical activity behavior. Participants in this particular study, as well as my larger dissertation, were individuals who self-reported a medical diagnosis of MS, who were between 18 and 65, and identified as being engaged in any physical activity. So they weren't necessarily meeting guidelines, but they were engaged in some physical activity. And as you can see in this table here from the paper, the larger study had a sample size of 55 for the qualitative interviewing that I'm going to discuss later. Only 35 of those 55 participated, but these are participant characteristics for the larger sample. So somewhere around an average of 48 years old, mostly female, mostly white individuals who, if you look at the bottom there, looking at the patient-determined disease steps score, that's a self-assessment of functionality. The range is from 0 to 6, 0 being more functional, 6 being less functional. These folks were on average around a 2 on that scale. So that means that they were more functional individuals. And then if you look at their Godin Leisure Time Exercise Questionnaire score, they were a 25.8 on a range of 0 to 91, meaning that they were not necessarily highly active. So they were active, but not highly active, functional, mostly female, mostly white, and somewhere around midlife. So again, this was a qualitative data collection in a subsample, so about 35 individuals. These data were transcribed and analyzed using a constructivist grounded theory perspective. And for those of you who aren't familiar with qualitative research, that's going to be that's a big word, but essentially it is a method for qualitative research that's really focused on trying to explain a process or a social phenomenon that's not very well studied. So you're trying to develop a theory of how a process or a social phenomenon occurs based on someone's description, multiple people's descriptions of how this phenomenon works for them. So you would pose a question like, can you walk me through from start to finish how you feel when you're doing X, Y, or Z? And you're able to see consistencies potentially across multiple people and create a theory from that of how this process actually works. And the result of that is a very messy figure like this one right here, where you see all of these different factors that are potentially influencing exercise type, time, and frequency in the middle. Now, I really want to focus on kind of that left side of the model, where we're focusing on fatigue onset, because again, this was a study brought about by the prevalence of fatigue. You'll notice that there are 3 different things that inform fatigue onset per the descriptions of participants. Those were body sensations associated with fatigue, body function associated with fatigue, and emotions. Participants described fatigue as an emotional experience. They experience frustration, disappointment with themselves, anger with their bodies, in addition to discomforting physical sensations like tingling, numbness, dizziness. And they also were able to pick up on, okay, I'm not necessarily as functional as I was when I started my exercise. I'm starting to experience symptoms like foot drop. I'm starting to realize that I'm not necessarily up to the caliber that I should be when I'm performing this particular exercise. And obviously, that fatigue onset and those things that influence fatigue onset will negatively impact exercise time, type, and frequency. So when you're actually in the bout, when they're in the bout of exercise, they're actively doing it, that fatigue is going to negatively impact their ability to continue in that moment. But it also contributes to what we termed exercise specific worry and defensiveness, which is an attitude towards exercise that is really oriented towards self-preservation, self-protection, and somewhat worry. The idea that these symptoms are causing me to feel worry, that I need to decide, is this something I need to continue doing in order to maintain my current my current state, or at least go back to homeostasis without injury, without any further exacerbation of symptoms. And that exercise specific worry and defensiveness, while it was present in that moment, so in that bout of exercise, and negatively impacted their exercise time, type, and frequency, it also contributes to their overall belief and ability to do physical activity. So thinking past this bout, this exercise specific worry and defensiveness, as participants described it, has the capability of reaching into future bouts, reaching into their longer term behavior and saying, there was that one time I did that exercise and I felt X, Y, and Z, which made me feel emotionally worried, uncomfortable, scared for my own safety. So I'm not going to engage in that kind of physical activity again. So really kind of extrapolating that and kind of interfering with their belief to do physical activity outside of the acute setting. However, despite these kind of negative experiences, participants were still able to express belief about the benefits of physical activity. They knew it positively impacts their lifestyle and it positively impacts their health. So that belief kind of carried them through that immediate bout, despite the fact that they were kind of contending with that exercise specific worry and defensiveness. And all that to say that this description and dialogue about worry was really valuable. It was a novel finding for this field that we're trying to uncover, why do people not be physically active? Why do they have the all or nothing mentality of, if I can't finish this bout, then I'm just going to quit? Well, some of that could be related to worry of their own safety, particularly in people with disabilities who have neurological condition. So physical activity practitioners could potentially benefit from seeking to understand this kind of mindset and this kind of mindset pattern, particularly as it relates to fatigue with this study, but I think with other types of symptoms and negative or adverse effects of physical activity acutely. And thinking about how that's going to actually impact programming of physical activity. So what is someone going to do for a day, and how do you actually program around that feeling? And moving forward, I wanted to talk a little bit more broadly about social interaction that was listed in my outline. So this is one of my master's thesis studies focused on adherence and continued participation in that wellness class that I described before. So kind of transitioning away from this very individual symptom-related experience to, let's talk about how adherence can be impacted by these larger exercise settings themselves, like where the people are actually doing the exercise. And what we noticed about that program was that people were coming back for years and years and years. And despite all the barriers that we know this population faces with physical activity, they were still present. And I wanted to know why. I thought it was really interesting. So I took a subset of participants from the actual wellness class. You can see from this demographics table kind of what the distribution was in terms of like disability type, their age, their race, gender, and how long they had actually been in the program. And we measured it in semesters because, again, it kind of corresponded with a credit course for students. So you've got anywhere from people who have been in the course for 15 semesters all the way down to like a newbie, and what would be influential for him in terms of continuing on in this particular program. So we tried to select a wide range, people who had been in the program for a while, people who had been in the program for a mid amount of time, and people who were new, to try to see if we could find some consistency and some reasons why they would want to continue participating. And again, kind of going into the methods, I'm not going to spend too long here, but this was a purely qualitative study where I performed interviews that encouraged participants to talk about their experiences within the class in like a deeper way, or even kind of giving me anecdotes or stories, the very contextual data. And those data were transcribed and analyzed thematically, which for those of you who are not familiar with qualitative research is probably one of the more common qualitative analysis methods, is to basically try to process this large data and think about it like a funnel where we're trying to iteratively code to where we narrow it down to these larger sub-themes and themes. So larger patterns that emerge from this data. And what we found was participants were talking about social interaction the entire time. When they were giving these stories, when they were providing their in-depth explanations of, this is why I feel this way about this, it's always about social interaction with the students. In particular, they talked about receiving motivation specifically from the students. Just as an example quote here, I enjoy the people, and because I enjoy the people, I'm more willing to do the exercises, point blank. Being around the students was more encouraging and motivating for this particular participant because they felt that the students were really invested in their long-term health and well-being. Participants also described accountability with students. And in particular, this became really useful when we started talking about this in terms of it being a course. Participants were aware that students were receiving credit for this course. So they said, if I don't show up, is this going to impact my student's grade? And you saw that consistently. And even when they realized, even when someone like me or Dr. McCauley would pull them aside and be like, no, it doesn't impact their grade, like it's okay, they still took ownership and responsibility of that and mechanized that as accountability, which was really cool to see that, they knew someone was counting on them every single time. So it made them more likely to come. They also talked about participant-student interaction in particular. And I wanted to emphasize that this was something that was kind of unique because this particular class also involved like group exercise type setting. So while you are in there with your student trainer, you're also in there with anywhere between 4 to like 8 other individuals from the community with a disability. So it was particularly the student participant, excuse me, interaction that participants in this study talked about. For example, they said that the students were chatty and positive and encouraging, like that actual interaction between a student and their demeanor coming into the actual practicum setting was influential for their motivation to continue. And then finally, they talked about the environment being supportive. And really what that means, or what that kind of was conceptualized by, was this idea that students really wanted these participants to have their own goals related to what do you want to achieve from this program? What can I help you achieve? And let's work together, co-construct an exercise plan that's going to make your goal act like achievable. But that little bit of autonomy, as you can see kind of in this quote, it meant a lot. That there wasn't someone talking at them, there was someone talking with them. That they were able to say, these are my goals, this is what I want to do. And the participant was shepherded in that direction using exercise by the student and not necessarily talked at. These participants really strongly valued their personal interactions with the students, more so than other unique aspects of the program. Like that's all they talked about. They didn't talk about the fact that it was free or that the equipment was specialized. They didn't talk about the fact that they were around other individuals like them. They were talking about the students. And so I think that shows that creating environments that encourage participation and adherence through personal interaction provides individuals with disabilities potentially the motivation needed to maintain exercise behavior, which is the long-term goal of exercise intervention. We don't want them to stay in our intervention forever. We want them to move on and to be able to have these kinds of exercise experiences on their own. And so providing that social interaction could be key to getting them to invest early in your exercise intervention so that they are able to transition off. Finally, I just want to highlight a study done by some colleagues of mine focusing on navigators. Now, when we talk about navigators in this context, we're talking about how do we actually deliver information related to adaptive sports and recreation participation for people with disabilities. And I know that for you guys in the residency program and things like that, you're learning about communicating resources with patients. And I thought this might be a really relevant study. So the aims of the study were to gain a better understanding of the resources, barriers, and facilitators of participation in adaptive sport and recreational activities, as well as to understand the preferences for a patient navigator service to help get them to those actual activities and mitigate some of these barriers to participation. So for this particular study, both parents of children with disabilities as well as adults with disabilities were surveyed. So this makes this kind of unique. You're getting two separate perspectives from like the younger end of the spectrum as well as the adult end of the spectrum. A total of 198 adults participated and 146 parents of a child with a disability participated. And you can see the demographics briefly listed there. This was a mixed method study, so there was a survey and a focus group component. I'm going to be primarily reporting the quantitative data. So those were collected via survey. The qualitative data was in focus groups, which will be highlighted in the very last table that I present from this particular study. But essentially what you can see, we're going to start with table 2, in illustrating participants' awareness of these actual adaptive sport opportunities. You can see that around 28% of adults who were sampled did not know of any opportunities to participate in their area in adaptive sport. And that in and of itself should be kind of a showstopper, right? At the end of the day, there could be more resources dedicated to communicating these particular programs. You can see frequency of participation. Around 42% of adults had never participated. 8% of adults participated daily. I'm not entirely certain under what parameters, but I think the weekly estimate is probably a little bit more applicable to what's going on within adaptive sport, probably in our area, with around 30% of individuals saying that they've participated. And then you can see on the bottom how often people are participating in physical activity or exercise of 10 minutes or more. And that's just trying to get an estimate of how many people are actually engaging in some form of physical activity, even if it's outside of that adaptive sport setting. And you can see about a quarter of them were saying more than 4 times a week of about 10 minutes or more. So it's approximately 40 minutes at a minimum. And that's not necessarily meeting guidelines, but it is at least a substantial step in that direction. Table 3 shows barriers to participation and preferences for a patient navigator. I'm going to try to break this up a little bit. So when they assess barriers in the survey, this particular study, they tried to assess these domains of barriers on a scale of 1 to 4. 1 meaning this is not a barrier for me. 4 meaning this is a serious barrier for me. And as you can just kind of scan these numbers, everything's kind of falling in this moderate range, this like 2 to 3. Like, yes, it is a barrier, but it might not necessarily be the most serious barrier. So that's something to acknowledge, is that participants felt across the board these things weren't necessarily as serious of barriers, period. But this table is really great because it offers comparisons between adults and children. And what we see is that expense of activity equipment is a more significant barrier for adults than parents of children with disabilities, which makes a lot of sense when we harken back to the beginning of the presentation where we talked about resources. Additionally, expense of the activity is a larger barrier, as well as transportation to and from the activity. Again, kind of hitting on this point of what can we do to increase physical activity participation and sport participation? Well, we need to start thinking about how expensive these things are. How are people going to get to and from them? And then, can they do these things independently versus in a facility? Now, if you look to the second section, navigator type, they assess this in the survey. 1 in these domains, again, kind of similar to before, 1 being least preferred, 5 being most preferred. And when you just scan the actual differences, if you look at the difference between parents and adults, parents of children with disabilities and adults with disabilities, you're not necessarily seeing a huge difference until you get to an individual or a peer with a disability, where you see that more adults want that as their navigator type, the person that's going to help them navigate these resources. More adults are asking for that than parents of children with disabilities. And then finally, navigator access, again, scale of 1 to 5, least preferred to most preferred. Across these domains, you see that more adults are preferring to meet with a service provider at a doctor's visit. So for those of you who are wanting to go into physical medicine and rehabilitation, this is kind of a cue to action, that there are people who are looking for access to these things when they step into your clinic. And I think that that's a huge piece of at least the dissemination of some of this information. And then finally, with the qualitative data, as I mentioned, it was a focus group. They did a thematic type analysis to try to glean what are the most important health outcomes that parents and adults want from these kinds of programs. And as you can see, parents of children with disabilities want their children to build peer relationships. And for adults, socialization or meeting new people is number two. That's number two in the priority list. And I really wanted to highlight that to kind of expand on the findings from my work at the University of Georgia, where social influence is so big and is so beneficial for this particular population when we're thinking about how do we maximize participation, incorporating some of those things might be key. So again, these results show a need for improved dissemination of these ASR resources, enhancing knowledge of physical activity guidelines and available ASR opportunities within the provider community is essential. So that's where hopefully you all come in to try to kind of bridge that gap moving forward. And again, social support is highlighted as a benefit of activity. That's what the people are hoping to gain. And that's consistent with what I saw in my other study. So the larger implications of these findings, if we think about exercise or physical activity in the ICF as the centerpiece, where our findings that we discussed tonight kind of sit are in these personal factors. So knowledge of resources, symptoms and psychological response to symptoms, as well as demographic factors and environmental factors. Whether or not someone's got access to adaptive exercise or physical activity space, in sports social support. So do they have fellow exercisers around? Do they have their trainer around? Do they have a coach around? But also thinking about out of sport social support, so caregivers and partners, and how can those people actually be integrated? So to kind of sum it up, while some factors that influence decision making around exercise are non-modifiable, like the presence of symptoms, incorporating participants' perspectives on these things and supportive strategies to move around, literally move around those symptoms, rather than ceasing movement could be key to continued adherence and persistence in longer term behavior. If you can teach someone how to move continuously and not stop moving, if you can teach them to modify in order to respect their symptoms, respect their feeling, but continue moving, that's a much more effective strategy than someone saying, I'm having symptoms, I need to stop, and then they leave it there. Practitioners, caregivers, partners, teammates, and coaches are instrumental sources of support. We saw how important that was. For those programming, exercise, or physical activity, creating opportunities to facilitate social interaction and buy-in are key. So if you are working towards creating these kinds of programs, trying to create a social interface is really important. And on that note, I wanted to just briefly discuss exiting organized sport, because while we all know if you've ever played a sport, once you exit that sport, it can be really hard to reestablish a physical activity routine. But for individuals who need adapted sport, this can be incredibly difficult, not only from like the adapted perspective of actually needing facilities for this, but also these social resources, these people that we're supporting, these people that were in their corner, especially in that in exercise setting or that in sport setting. So I wanted to just point you guys to NICPAD. I don't know if you guys have ever heard of NICPAD, if you've explored this resource before, but this link is in my presentation. I'm happy to share my slides. NICPAD is a continuously federally funded program that's led by Dr. Jim Rimmer at the Lakeshore Foundation, which Lakeshore Foundation is actually also the Paralympic training site for the United States Paralympic team. It's one of the training sites. So NICPAD is housed in this larger adapted sport facility, housed out of. And NICPAD's created a whole bunch of resources related to how to actually adapt exercise for individuals with movement impairment. And they have so many videos, free access, complete library of videos to actually help people modify their own exercise routines and perform their own exercise routines. However, in the context of social support, NICPAD also has NICPAD Connect, which has several outlets for social support. For example, creating mentorship programs, as well as the NICPAD Coffee Club. So people are actually able to connect through NICPAD, not only talking about, their struggles with their behavior change, but also just maintaining that social support, which could be really, really key for maintaining long-term behavior, as we've discussed. So with that, I'll just give you a couple of takeaways. Consider the individual as well as their context when understanding behavior. Sounds simple, but it's consistent practice. It really is a consistent practice that you have to engage in order to actually design effective behavior change and think about behavior change differently. Social interactions and support are key to adherence and maintenance of active lifestyle for people with disabilities. Again, might sound simple, but given the evidence, continuing to call upon or provide social support within your activity or intervention could be key to providing motivation to push past the inevitable barriers to activity. Social interactions and support, both within and outside of sport, impact athlete development as well as participation in sport. So again, these social settings are really influential in both arenas, and we need to think about how we incorporate that as our modifiable factor, the things that we can try to provide structural support for. And after participation in organized sport, finding new ways to connect and receive social support can be difficult. So trying to find those resources in your community and being a provider who is actively supplying those resources is going to be really key to keeping people active throughout the lifespan. And with that, I can conclude. I know I'm probably close on time, if not over time, but I'm happy to answer any questions if you guys have them. Thank you.
Thank you so much, Dr. Ware, for that presentation. I thought it was really helpful and kind of like hit the nail on or the nail of the head of the nail. I'm messing it up, but anyways, it's right on point with the Adaptive Sports Coalition, and I think a lot of the desires of what a lot of the people in this coalition are trying to do. And I think it's just really helpful for all of us to to learn about this type of research. I this is the first time I'm really hearing of this type of research that's informing the development of this type of programming and how we can really consider the kind of the needs and the desires of participants and like improving adherence, like you said. My question is, how have you kind of seen this type of research be implemented into types of training? So whether that's with PT or with medical students or with residency programs or any other kind of training programs for, all of our health professionals. Like, have you seen this type of research kind of be incorporated into the training and where, like, at what point can we start picking this up? Is it this in training? Is this, more um, um, kind of showing this off to also professionals that are working now that already have experience, working with these populations?
Yeah, that's a great question. So when I was, as I mentioned a million times, when I was at the University of Georgia, that course was designed for undergraduates. And so that was their first exposure, most of them, to working with a person, period. And they all wanted to go into allied health. So PT, OT, all of that. Physical therapy is very much ahead of the curve, I would say, in terms of integrating this kind of stuff into their curriculum compared to some other fields. I will say the American College of Sports Medicine's made a huge effort to try to integrate at least exercise and the concept of exercise as being medicine into medical school's curriculum. That program is actually called Exercise is Medicine. It's pretty well advertised across the American College of Sports Medicine, and there are several members of the American College of Sports Medicine who are faculty at medical institutions who are instrumental in providing the training, at least related to exercise, the benefits of exercise, and kind of the structural framework for how much exercise people should be getting and prescribing that as a physician. But in terms of like the behavioral piece, if I'm being honest, I have not necessarily seen as much of that in certain settings related to education. I would like to see more of that. And I think that that's just really, that's going to be instrumental for long-term health of these patients, and that's everyone's goal. So I think it's kind of creating that crosstalk between our field and medical education that hasn't quite necessarily happened. And I would highly encourage students who are in these kinds of programs, who are interested in this kind of research, to seek out resources. I mean, I'm here in the area. I'm more than happy to help if you're interested in behavior and trying to understand behavior. There are several people on our campus, I think, who would be really willing to sit down and help as well. But it is an area that I think needs a little bit more crosstalk.
Okay, we have maybe 2 more minutes for any additional questions if anyone wants to get one in real quick.
I'm glad I ended without, I knew I was getting close on time. So I was like, I don't want to keep you guys because I know it's late, but
This was perfect. You timed it perfectly. So, um, I have one more quick question, if that's okay. So you mentioned this class that was in Georgia. Is this something that's you think is replicable, like in other PT OT schools? And do you feel like that could be beneficial for also the DFW area as well?
yeah, so that's I think I think in my time teaching that course, I gave probably about four different presentations at four different national organizations around how do you structure these kinds of programs because they are so mutually beneficial. I mean, you're benefiting the community, you're serving people who need this kind of resource, but you're also providing students with hands-on experiences and giving them kind of a leg up in their undergraduate education before going on to professional training. Um, it's one of those things that seems like a no-brainer, a win-win, but there are so many regulatory issues that you have to think about when you're trying to create some of these classes, like liability issues related to bringing folks onto campus. And if you choose to have your students go to those folks, liability issues there, you really need administrative buy-in to kind of work past those types of hurdles. But that's actually something I've really been excited about trying to start here. I'm still in partnership or still trying to work some things out with resources around our area here in DFW, but that would be something, it's a dream for me to kind of have that class replicated here at UNT. I think it's something that a lot of universities, again, it's a win-win for the students, but I think a lot of universities could reflect on potentially reaching into their communities in different ways, even doing like diabetes awareness programming and things like that, even if there's not necessarily quite the market that we have in DFW for disability related programming, there's still ways to kind of provide that structure for other groups that are underserved. So I would like to see more of that. It's a little pet project of mine. Maybe I wait a couple years, closer to tenure before I start working on that. But it's something I see being kind of the future of how do we start closing some of these gaps in resources for this particular population. If we're able to provide this service, let's do it.
Well, we're very happy to have you here in the DFW area now, and have you on board with the coalition. So thanks so much for the presentation. That concludes our education series tonight. I'm going to go ahead and post the link to our YouTube channel in the chat. And we'll probably get the recording out some point within the next week or two. So if you missed anything or want to revisit it, you can visit it there. So thanks everyone for joining us.